Welcome to Talking About Tumors with Ryan and Ryan. I'm Ryan Holstead.
And I'm Ryan Quinn.
And today we're going to overview the approach to metastatic breast cancer, specifically for hormone-positive, HER2-negative disease.
To everybody who took the hematology boards, congratulations and good luck. And congratulations also to the internal medicine residents that are listening on their match. I know the match was this week, so congrats, and everything always works out the way it should.
Alright, so today we're going to move from the adjuvant setting and take a look at advanced disease with breast cancer, namely in the hormone-positive space.
So today we'll be talking about hormone positive, but we'll be talking about HER2 negative. There are patients that are what we call triple positive, where they're hormone positive and HER2 positive. Those are treated more like HER2 disease, so we'll be speaking about those, at a later time.
This is a pretty variable presentation, and you may have patients who are presenting with de novo metastatic disease. One of the classic presentations is the, quote, neglected breast, unquote. This would be someone who might have had a lesion on their breast for a number of years and did not seek medical care. Sometimes these masses will become fungating or quite painful, and during your workup you'll find that there's also been spread to the bones or distant organs. You may also have patients who previously had adjuvant therapy and now are coming in with a painful bony site or maybe some abnormalities noticed during follow-up. It's important to keep in mind that hormone-positive breast cancer is classic for having, albeit rare, very late presentations, sometimes up to 20 years later. And this just made the news recently with Olivia Newton-John passing away after a late recurrence of her breast cancer. Rarely you'll also have a disease presenting as a rapidly progressive disease at first presentation, although this is more typical of your HER2 disease or triple-negative breast cancer.
The most common sites of metastatic disease are bone, lung, and liver. Unlike lung cancer, where brain mets are particularly common, where everybody gets a brain MRI, it's not as common in breast cancer. It's a little bit more common in HER2 positive and triple negative than it is in hormone positive, but not so common that we routinely check MRI brain for everybody. Obviously, if they have symptoms or any localizing findings on physical exam, then you would want to get a brain MRI, but otherwise there's really no need. It's also important for anyone who has metastatic disease to always rebiopsy. One, just to make sure that this is in fact recurrence or metastatic breast cancer and that you're not missing another malignancy. But also it's important because the markers can change. So ER, PR, HER2, they can change over time. And if you look at different case series, there can be up to 10 to 15% discordance between the primary tumor and sites of metastasis.
There's a couple rules of thumb to keep in mind with metastatic disease. Unlike colon cancer, we do not have data to support an oligometastatic approach. So if someone has one or two metastases, usually you're going to treat this as diffuse disease with systemic therapy. There's some small case series, usually single center, where patients might have like a very small focus of disease in a bone, which is treated with radiation. But this is really a highly selected population and would not be the standard patient that you would see with 1 to 5 metastases. In general, if you're going to be treating this as metastatic disease, you're not typically going to perform surgery on the primary breast lesion. This has not shown improvements of overall survival, and often initiation of systemic therapy, which is life-prolonging, may be delayed due to recovery from the surgery itself. Even a fungating lesion might start to regress and heal with time. If it is very painful at the initial presentation and will not respond to topical or oral analgesics, you can consider radiation, as this has a much shorter time to recovery.
Like in other cancers, there are tumor markers that are relevant for metastatic breast cancer. We don't use these in the screening setting or in the adjuvant setting, but you can see this sometimes in clinic. People will check tumor markers. So the ones specific for breast cancer are cancer antigen 27.29, and there's also cancer antigen 15-3, and we will also check CEA because that can also correlate with the tumor burden. You never want to use these in isolation. You want to make sure that you're confirming any uptrends with imaging. You would never want to change treatment just based on the numbers alone.
And on that note, as far as being confident about progression, especially if a patient has bone-only disease, it's important to keep in mind some limitations with bone-related imaging. Sometimes when you have a patient who's responding, you may see their tumor markers getting better, their pain scores going down, but then you do a follow-up bone scan or PET scan, and you'll find that the bony lesions are brighter, albeit not more of them. It's important to keep in mind that sometimes healing bone, as you remove the tumor, may appear as to look at like progression on the radiograph, and always see the patient in front of you, not necessarily the spots on a scan.
Yeah, definitely a good point.
All right, so moving on to the approach to systemic therapy. With estrogen or progesterone receptor positive disease, our goal is often to delay chemotherapy as long as possible. And we have a lot of hormone-targeted therapies that are highly effective. Many of these patients will live for years and will have progression-free survivals measured in the orders of many months to years. Very different than the GI malignancies we've talked about previously. The one exception would be patients who present with visceral crisis, which would be a high burden of tumor. Once again, usually something we're going to see more with triple negative disease, but if someone has a high tumor board in the abdomen, maybe they're developing signs of abdominal pressure or even hepatic failure, you're going to often use systemic therapy to get a faster response rate, as hormone-based therapies are going to have a delayed response and a slow response.
Another example of this is anyone who has dyspnea from like lymphangitic spread. That's another type of visceral crisis that I've seen.
Absolutely.
While we typically start with endocrine therapy for these patients, it's important to know, how sensitive patients will be to endocrine therapy, which can sometimes correlate with the ER/PR positivity. ER positive is considered anyone with an ER or PR greater than 1%. However, in patients with a ER or PR of 1 to 10%, this is considered like ER low, and you may not have the best response to endocrine therapy. So you can definitely still use it and should, but if you really need a rapid response or the patient's very sick, you want to keep in mind that they may not have the best response to just endocrine therapy.
Yeah, follow these patients closely. Sometimes they can behave a lot more like a triple negative patient. The agent that we're going to start with is really going to depend upon whether or not we classify a patient as endocrine resistant. Endocrine resistant comes into play if a patient has progression while still on their adjuvant hormone therapy. So if they're in that 5 to 10 years while they're taking tamoxifen or an AI, and then they have metastases present, this would be considered endocrine resistant. Also, if they have progression within 12 months of completing their hormone therapy, this would be considered resistant as well. A high yield fact to know are the primary mechanisms of resistant. Classically, these are divided into 4 different categories. By far and away, the most common one, approaching 50%, is the ESR1 mutation. So this is actually a mutation on the estrogen receptor that leads to a constitutively active receptor. Basically, it removes the need to have estrogen binding to the receptor in order to be active. So tamoxifen trying to block the receptor or an AI removing the estrogen has no effect on inactivating the protein in these when this mutation is present. Other possibilities are cell cycle autoactivity. So this is through our, if you want to think back to your fun med school days, the cyclin-dependent kinases. Most commonly, we talk about cyclin CDK4 and 6. These are often found to be overactive in resistant breast cancers, and this is downstream to the estrogen receptor. So these can still lead to increased cell division even when your estrogen receptor is blocked. There may be secondary kinase cascades that are happening due to the P13K pathway or a lack of expression of the protein P10. Or finally, there may just be a loss of your estrogen receptor expression. And these patients will transform into a more triple negative or HER2 positive disease, which can happen in the midst of treatment. So if you have someone that's really progressing and behaving differently, maybe progressing quite aggressively, you might consider rebiopsying and retesting for estrogen sensitivity.
Yeah, as far as I know, I don't think that there's any utility as of now in checking for ESR1, right?
No, that's it's experimental. There was recently a trial that came out looking to see if surveilling for this can predict resistance sooner and starting an active second-line agent sooner, but it has not yet come into clinical practice, but may in fact do that in the next 5 to 10 years. We'll have to see.
Good to know.
Back in the olden days, when tamoxifen was our only option, this was used as a first-line agent. As AIs came out and were thought to be more active, these were compared to tamoxifen. What we didn't reference during the prior episode, there were actually a few generations of AIs that came out. The first 2 did not actually end up being superior. It wasn't until the 3rd generation, which would be the agents that were more familiar today, such as letrozole and anastrozole and exemestane, that we managed to find a significant benefit to tamoxifen, with both a progression-free and overall survival benefit. The first trial to show benefit was using letrozole, and this showed an improvement of time to progression from 26 weeks with tamoxifen to 41 weeks with letrozole. A later meta-analysis comparing all the AI trials to date as of 2006 showed that overall survival benefit in favor of an AI with a hazard ratio of 0.87. So with the exception of a premenopausal patient who does not want to go through ovarian suppression or oophorectomy, you would be starting an AI as part of your backbone for systemic therapy.
So getting into current first-line treatments, the addition of the CDK4/6 inhibitors to an AI has really now become pretty much standard of care for first-line treatment, with the exception of patients that are frail or you're worried about side effects. In those patients, you can consider just an AI alone. There are currently 3 different CDK4/6 inhibitors, which we did reference in our last episode, but just to go over them again, there's palbociclib, ribociclib, and abemaciclib. These are all very similar molecules.
They're nearly identical molecules when you look at them side to side. If you have some free time, take a look at their Wikipedia pages and put them all next to one another.
Yeah, so they're all very similar, and they've never been directly compared in head-to-head trials, but they all have very similar trials, both in the first and second line setting. So in the first line setting, the addition of the CDK4/6 to an AI has shown to improve progression-free survival and, in some cases, overall survival.
Just before we go into the outcomes for these trials here, it's worth knowing how these drugs are given. Both palbociclib and ribociclib are given as cyclic drugs, as 3 weeks on, 1 week off scheduling, whereas abemaciclib is given as a twice-a-day, everyday medication with no week off. Palbociclib's side effects are most notably, as we mentioned last discussion, is neutropenia, fatigue. Ribociclib has also neutropenia. It is associated with an elevation of LFTs, a little bit higher rates than palbociclib, risk of increased QTC. Recommendations for ribociclib, given the QTC prolongation risk, is to get an EKG prior to initiation of the therapy, an EKG at week 2 and at week 4. Abemaciclib, its major side effect is diarrhea, and this is worse often within the first 2 to 4 weeks on therapy.
Yeah, it's good to know the toxicities because the efficacy, as we'll see, is very similar, so we pretty much choose based on the toxicities.
One thing I should mention, and I think we did discuss this last time, was that the neutropenia we see is not like the neutropenia in chemotherapy, and there's rare rates of actual neutropenic fever and infection developing, as these tend to be more mild neutropenias and of a different mechanism than ablative chemotherapy.
Yeah, definitely. So getting to the trials, we won't get too into the nitty-gritty of each trial, but just to go over kind of the basics. So for palbociclib, there was the Paloma 2 trial, which was published in the New England Journal in 2016. It was a phase 3 trial looking at only postmenopausal patients in the first-line setting, ER positive, HER2 negative, and this was comparing palbociclib plus letrozole versus letrozole alone. When it was first published in 2016, it did show a progression-free survival benefit of 24.8 months versus 14.5 months, which was statistically significant with a hazard ratio of 0.58. At ASCO of this year, they presented the overall survival data, and there actually was no overall survival benefit. So at a follow-up of 90 months, the overall survival was 53.9 months versus 51.2 months with a hazard ratio of 0.95. Not statistically significant. I mean, pretty promising that the overall survival was 51.2 months. Toxicities were, as we mentioned, neutropenia. Neutropenic fever was uncommon, as Ryan just said, 1.8%. Fatigue, nausea. You can actually get alopecia with these drugs, which is important, to kind of warn your patients about. 30% of patients in this study did have grade 1 alopecia.
Yeah, I mean, this is an incredible overall survival. I mean, we're looking at patients living for nearly 5 years of metastatic breast cancer, which is the longest survival data to date. So certainly a sobering overall survival benefit. I mean, even the patients who got AI alone lived for about 51 months, and this is despite having a substantially shorter PFS. And we'll discuss in a moment, some possibilities for the reason behind this.
Okay, so getting into ribociclib, the MONALEESA 2 trial, this was a phase 3 trial, also looking at only postmenopausal women with ribociclib plus letrozole versus just letrozole alone. This was also published in the New England Journal in 2016, and when it was initially published at 26-month follow-up, there was a progression-free survival benefit, 25.3 months versus 16 months, with a hazard ratio of 0.56. Ribociclib, interestingly, actually did have an overall survival benefit, which was reported this year in the New England Journal, 6.6-year follow-up, and the overall survival was 63.9 months versus 51.4 months, with a hazard ratio of 0.76. So kind of interesting how this had an overall survival benefit, but palbociclib did not. Again, toxicities, neutropenia, leukopenia, increase in LFTs were the main things that they saw. And then the last trial for abemaciclib, the Monarch 3 study, which was published in the Journal of Clinical Oncology in 2017. This was looking at abemaciclib plus letrozole or anastrozole versus just the AI, either letrozole or anastrozole alone. Again, only in postmenopausal patients. So in the initial publication in 2017, the progression-free survival was not yet reached in the abemaciclib arm versus 14.7 months in the placebo arm. There was recently a second interim analysis done that was presented at ESMO of this year, which at this point, the overall survival is still not statistically significant. There is kind of a trend, but we need more follow-up really to make any definitive conclusions. But at this point, at a median follow-up of 5.8 years, the overall survival was 67.1 months in the abemaciclib arm versus 54.5 months in the AI alone group. The main toxicities that we saw in this trial were diarrhea, neutropenia, and leukopenia.
So we have 3 very similar first-line trials, all compared to AI, none comparing to each other, and all 3 are showing a significant improvement in progression-free survival. It certainly is interesting with the differences in overall survival. We see we do see a statistically significant overall survival in ribociclib.
Yeah, I think that there's a lot of confusion as to why there is a difference in the overall survival benefits between palbo and ribo. One thing that the investigators did mention is that in the palbociclib, the Paloma 2 study, there was actually a significant amount of missing data. A lot of patients were lost to follow-up, 21% in the placebo group versus 13% in the palbociclib group. So whether or not this could have contributed to that, is just kind of unknown. It's kind of a shame that they had a lot of missing data.
It's also important to look at when you're analyzing these trials, patients who are getting CDK4/6 inhibitors in the second-line setting. As we'll show shortly, these have shown overall survival benefit after progression on AI. Certainly with international trials, patients might not have access to these drugs outside of trial, and we don't yet have the final publication for the overall survival on palbociclib, so once that is out, it'll be interesting to compare post-protocol therapy between that trial and the ribociclib trial. Historically, a lot of the trials that end up developing standard of care regimens would often require 2 positive trials side by side, due to the 5% risk to have a false positive.
It's also important to note, looking at just premenopausal women, the only trial that specifically looked at this was the Mona Lisa 7 trial, which looked at ribociclib plus an AI and ovarian suppression versus just an AI and ovarian suppression in premenopausal women. And this was a positive trial with both a PFS and an OS benefit. So something to consider when you have a premenopausal woman, that the only trial that actually looked at this was using ribociclib.
So moving into the second-line setting, I think it's fair to say the standard of care at this time would be using a backbone therapy that includes fulvestrant. And this is a SERD, or a selective estrogen receptor downregulator. So unlike tamoxifen, which is actually blocking at the receptor, fulvestrant binds tightly at the receptor and actually leads to destruction of the estrogen receptor protein itself. This is advantageous because for those patients with an ESR1, these autoactive estrogen receptors, we're actually destroying the protein. So even if they have this mutation, we're still ending up getting a response benefit. This medication is highly effective in patients who've proven to be resistant to AI. There's been some trials looking at comparing it to AI as a first-line agent, although this has become less clinically relevant in the CDK4/6 era. There's been also some trials looking at combining this with AI, and for the same reason, not necessarily has made its way into standard of care. It's not the most convenient medication to give. Currently, the only approved agent is a IM injection given as a loading dose at day 1, day 14, day 28, and then moving into once a month treatment. Generally well tolerated, however, the main side effects being injection point pain, and occasionally we can see an elevation in LFTs. Some patients have some nausea and vomiting, although I haven't really seen that in practice. As with AIs, we can see osteoporosis with long-term use of this medication.
So in the second-line setting, there have been studies, as we said, with each CDK4/6 inhibitor in combination with fulvestrant in patients that have already had progression on an AI. At the risk of just presenting too much data to you guys, because they're all very similar trials, again, looking in the second-line setting.
We'll just present the overall survival benefit looking at fulvestrant with a CDK4/6 versus fulvestrant alone on patients who've progressed on AI or tamoxifen. And we recommend you take a look at those studies yourself if you want to read into them in more detail. But in general, these have shown improvements in survival, although much of this data still remains immature, with the initial palbociclib overall survival data being 35 versus 28 months, abemaciclib being 47 versus 37 months, and ribociclib 52 versus 42 months. So although the data continues to develop, it certainly looks like there is an added benefit here, and that's due to the fact that often after we progress on these agents, our options get a lot less effective and a lot more toxic. Being able to delay post-anti-estrogen therapy is very important. Unfortunately, what none of these questions have yet asked is, when do we give our CDK4/6, either in the first or second line, or do we continue it as we progress on AI? And I'm sure there'll be trials at least asking that second question. I don't think there'll be as many trials seeing whether or not we can delay CDK4/6 safely in the second line, just due to the nature of how trial funding works.
It'll be also interesting to see, now that we're using some CDK4/6 in the adjuvant setting, just if that limits the use in the metastatic setting.
Yeah, certainly a concern that I have about moving these agents up earlier is we may be taking away a very effective therapy for those unfortunate patients who do have a relapse, even though we may be reducing a small proportion of those who relapse using the drug sooner. As I've just mentioned, our options get a little bit more limited after progression. After an AI and fulvestrant-based therapy, we then see if we can safely target another mechanism of resistance, namely through the P13K pathway. So this is a parallel growth and proliferation pathway to the RAS pathway, which we've discussed previously. And this is a high-yield one to know, and that's the kinase cascade of P13 to AKT to mTOR that leads to increased cell division. Also, as part of this pathway is the inhibitory molecule P10, which will block the activation of AKT by P13K.
So we have a PI3 kinase inhibitor, which is alpelisib, which can be used in patients that have a PI3 kinase mutation, which I've seen numbers quoted as high as up to 40% of patients with hormone positive can have these mutations. So more common in hormone positive than in your triple negative or HER2 positive patients. This was studied in the SOLAR-1 trial, which was looking at alpelisib plus fulvestrant versus placebo and fulvestrant in patients that had progression on an AI. The primary endpoint was progression-free survival, which was almost double, 11 months versus 5.7 months in the PI3 kinase mutated patients. They also looked just as kind of a proof of concept at patients that had a wild type PI3 kinase, and there was no benefit seen with alpelisib in those patients. The final overall survival data was presented in 2021, 39.3 months versus 31.4 months, about an 8-month increase in overall survival with a hazard ratio of 0.86. This actually didn't end up being statistically significant, interestingly, but there was a numerical benefit. Important to know the toxicities because this actually can be a difficult drug to tolerate, particularly with hyperglycemia. So 37% of patients will get hyperglycemia on this drug, 0.7%, so almost 1% with grade 3 or 4. The eligibility criteria for the trial, because this was known to cause hyperglycemia, was to have an A1C less than 6.5. So I would keep that in mind if you're starting this on a patient of yours. You definitely want to get them into primary care or endocrine to get their sugars controlled before you start. And you want to make sure the A1C is well controlled before starting. Other toxicities that we see are rash and diarrhea in about almost 10% of patients. I had a patient on this who was complaining of blurry vision after starting. It was actually from hyperglycemia. Her sugars just went completely out of control. So make sure you have your endocrine or primary care colleagues on board.
Just as a FYI, there's a few different P13K inhibitors out there. They work on different subtypes. In the case of alpelisib, we're inhibiting subtype alpha. You will also come across in the lymphoma space a gamma, a P13K inhibitor. They're different drugs with different toxicities, so it's important to not confuse the two. And the gamma subtype tends to have more of immune-related toxicities versus what we're seeing here. So another tool in our arsenal that has FDA approval, albeit with some controversial data, is everolimus. This is an mTOR inhibitor, so that's working on the same pathway as alpelisib. This was studied in the Bolero-2 trial, combining this drug plus exemestane versus exemestane alone on patients who've previously progressed on an AI. This was initially approved after an interim analysis showed an improvement in progression-free survival of 6.9 versus 2.8 months. This was with significant toxicity, namely grade 3 or 4 stomatitis up to 8%. And what that means is having mouth sores that are so bad that you end up being hospitalized and needing IV hydration. There's also grade 3 to 4 hyperglycemia up to 40% too. So some overlap and similarities to alpelisib with the latter point there. In fact, 30% of the patients had to stop this drug early due to serious adverse events. A follow-up analysis, significant overall survival was not shown, with overall survival shown at 31 versus 26.5%, with the confidence interval crossing the significance. There's been a lot of commentary, chief of it by Dr. Tannock and colleagues, looking into why we've seen an improvement in PFS but not OS in this study. Has often been cited as a good example of what we call informative censoring. So if you have reviewed oncology-based papers, you'll see those famous Kaplan-Meier curves where you'll see the control arm and the trial arm and individual curves with representing either your progression-free or survival basis. If you've looked at those, you may see that there's some little vertical hatches that go through those curves. Those vertical hatches are censoring events. And what that means is a patient who has somehow either come off trial, been ceased to be monitored, and they're considered for statistical purposes to be at whatever outcome they were at the time of censoring, whether that's progression-free or following progression. When patients stop a drug early due to toxicity, they're censored as if they have not had a progression. This becomes relevant when you have a very toxic drug and you have a significantly higher number of patients stopping drug early on the trial arm, having censoring, appearing to be progression-free when in fact they're no longer being followed on trial. The reason this matters is typically the patients who are more likely to stop the drug are going to be your frailer patients who are more sensitive to being either dehydrated or hyperglycemic. And Dr. Tannock has argued that this may have actually led to the PFS seeming better as they ended up strengthening their experimental arm due to the remaining patients being the best candidates. Once we got into overall survival, which didn't take into account that censoring, those patients would be still followed for survival outcomes, is why we lost the survival benefit. I think the bottom line is that this is an active drug and there may be a benefit, but you certainly have to be very careful with your patient selection and cognizant that the amount of toxicity that they may receive may not be worth the small survival benefit that you're obtaining.
It's considered a targeted agent, so something that you're using to avoid chemotherapy, and it almost seems like the toxicities are similar to chemotherapy, so are you really sparing the patient, that much toxicity by giving this instead?
One prior professor pointed out to me, we often think of targeted drugs as being better because they're not chemotherapy, but the point he made is chemotherapy is given often in cycles, and when you get a cycle, you'll often feel unwell for those first few days, but then maybe get back to baseline for a couple weeks before the next cycle. Whereas with a targeted agent that you take every day, even if you don't feel as unwell as that day of chemotherapy, you're going to feel generally unwell for the entirety of time on the drug. And if our goal is to help people live longer and feel well for longer, we may not be always accomplishing that with these highly toxic drugs.
Yeah, definitely a good point. I have had some success, or I've seen some success with using dexamethasone mouthwash for the stomatitis, but it still can be pretty severe. So after we've exhausted these options, the only treatments that are left are chemotherapy. Many of us will reach for capecitabine, given that it's oral and pretty tolerable. The main side effects being cytopenias and diarrhea, and some skin changes. And then, we really want to minimize toxicity in these patients, so we really use single agent sequential chemotherapy agents, whether it's taxanes, anthracyclines. You want to use them as a single agent rather than combinations. Keep
in mind, if the patients had anthracyclines in the adjuvant setting, they may have already exhausted their lifetime dosage, but depending on which regimen they're treated with adjuvantly, they may still have some additional room to go. There's many chemotherapies out there, all with phase 2 data showing response rates or progression-free survival rates. The number of times you're going to run into actually using these is pretty rare. Keep in mind, these patients are now living on median 5 years, and some patients I've seen well past 10 years before they are even discussing moving away from hormonal therapy. From my experience, it's often a very difficult discussion to have when you have a patient who's been on hormone therapy for many years to say, now we're going to start chemotherapy. And there's a psychological harm to many patients who start to view their disease as being more of a disease once they're running into chemotherapy. This is a bit more toxic, and this has a lot more of a stigma behind it. I really try to present capecitabine as being a convenient chemotherapy, but even still, it is chemotherapy. And I've had many patients who absolutely refuse this, and then I have to try to stretch out my hormone therapy as long as possible, even beyond progression for a few months, to try to delay the time before we don't have any option.
There are some new treatments that we're going to save for our next episode, our latest and greatest. I'm sure everybody's heard about ASCO this year, talking about trastuzumab deruxtecan in HER2-low patients, as well as sacituzumab govitecan. So we'll save that for our next episode and dive into the data for those two.
Yeah, as well as the role of bisphosphonates or bone-modifying agents. And these are also very effective adjunctive therapies to improve outcomes in these patients. To kind of sum up the developments, I think it helps to look at our progression-free and overall survival. Once again, we're now seeing in the most modern trials that patients with metastatic hormone-positive breast cancer are living for, on average, 5 years. These are clinical trial patients, so those you see in clinic may not live as long, but regardless, we're talking about disease that's measured in years, not necessarily always months. Thinking about where we were when we just had tamoxifen, we were dealing with a first-line agent that lasted for approximately 6 months. With the advent of AIs, we had moved that up closer to 12 months. And with the combination of an AI and CDK4/6 inhibitor, we're now looking at initial progression-free survival of 2 years. I think some major questions right now is how do you approach a patient for first-line therapy? And I think there's certainly a good argument to use a CDK4/6 inhibitor in AI. I think there's also a good argument for some patients who have maybe a lower burden of disease, or maybe you're a bit older, or maybe just don't want to come in once a month for lab work and instead come in every 3 months for imaging to see that their drug is still working, to start them on an AI alone. I mean, the data hasn't conclusively shown that starting the CDK4/6 sooner is going to help your patient live longer. And you may be able to preserve a good quality of life for a good period of time with just a single pill.
So in the absence of comparative data and head-to-head trials with each CDK4/6 inhibitor, right now we're really choosing them based upon toxicities with, Bema having diarrhea, Ribo and Palbo having, more significant neutropenia, with ribociclib having QTc prolongation, elevated LFTs. So you'd really want to tailor the drug based on, what side effects you're expecting. And for premenopausal patients, you may want to consider ribociclib, given the MONALEESA-7 study that was looking specifically in that group.
And once you've become resistant, showing definite progression to an AI. Keep in mind these are often slowly progressing diseases, so you may see some mild progression on your first follow-up scan. That may not be necessarily a reason to initially give up your treatment, but when you do end up progressing into second-line therapy, standard after an AI would be a fulvestrant with or without CDK4/6 inhibitors, depending on what you gave in the first line. After fulvestrant, you then may want to consider, depending on your patient's fitness, something that's going to work on that P13K mTOR pathway, namely alpelisib if they're P13K mutated, or everolimus if they're not, or if they've already progressed on alpelisib. After everolimus, we're going to discuss some of the most recently published options next episode. In addition to those, there are single-agent chemotherapies, which are effective options. It's just ends up having some additional challenges for your patients who are now getting IV infusions, with the exception of capecitabine. So really consider that being your first go-to chemotherapy if the patient's a candidate for it.
And always remember to rebiopsy, once you have metastatic disease, because again, you may not be dealing with hormone positive, HER2 negative disease anymore. It could have changed, so make sure always get another biopsy to confirm.
We hope today's talk was helpful. We look forward to moving into the latest and greatest talk next time, and welcome any questions through our Twitter or email.
Yep, thanks for listening. Hope everyone had a good Thanksgiving, at least American Thanksgiving, and our next episode should be coming up before the holidays, so we'll see you next time. Happy December.
Bye for now.
Bye. For more information, follow us on Twitter at Talking Tumors, or feel free to email us at talkingabouttumors@gmail.com.
Please rate and review the podcast. We really appreciate it.
And special shout out to our friend John Kim for all of his musical talents.
And he is the composer of the music that you're hearing right now. Talking About Tumors is not medical advice.
For medical advice, please contact your own healthcare provider.
Opinions stated on this podcast are by the Ryan who said it and no one else. We have no financial disclosures, and this is done purely on our own time, to the sake of our enjoyment of the field of medical oncology. Thank you for listening, and see you next time.